Hello, Assalamu alaikum, and welcome to another program of Health is Wealth. I am your host, Shabnam Riaz. And you know, it's been wonderful to be able to do a follow-up program now. In our last episode, we talked about the Pink Ribbon Breast Cancer Awareness Campaign, and our guests as well. We're all supporting the Pink Ribbon Campaign for the month of October. What is it? And that's what we told you about in the last program. It's to raise awareness about breast cancer and how it can affect your life, and also how to, you know, realize that are you at risk of developing the disease and what you can do for that. So for today's program, in follow-up to the last one that we had last week, we have our experts with us, and we're very happy to have Dr. Mohammed Farooq, consultant radiation oncologist, and also Dr. Gamran Rashid, consultant oncologist, diplomat, American Board of Internal Medicine. Thank you very much for being with us.
Thank you. Welcome.
Okay, so before we speak to our experts, we're going to have a look at this report.
For many people, the way in which radiation therapy works to destroy cancer cells is a mystery. Radiation therapy is delivered using a machine called a linear accelerator. The radiation is generated inside the machine, which accelerates tiny particles called electrons. These electrons produce high-energy X-rays. These X-rays are invisible, much like those used when you get an X-ray or CT scan, but contain much more energy. The beam of X-rays must pass through a hole created by lead blocks in the head of the machine. Since radiation cannot pass through the lead, the radiation beam can be shaped before it leaves the machine. Cancer cells divide more often than healthy cells. By damaging the DNA, it makes it very difficult for those cells to divide again. Damaged cells will then die without dividing. In order to target the cancer cells, which are often deep inside the body, the radiation must pass through and come close to some healthy tissues, especially the skin. By delivering radiation over a series of days and weeks, healthy tissues are given a chance to repair themselves between treatments. Nonetheless, some healthy cells will be destroyed by the radiation. The amount of radiation that will pass through healthy tissues is kept as low as possible.
Okay, welcome back. We hope you found that report informative. Now, in our previous program, we started at the very beginning. Who's at risk for breast cancer? The screening involved, things that affect people who can get the disease. So now we're going to go on to the next step. Dr. Gamran, now, you know, a woman is diagnosed. She's been through all the screening. She's been through all the tests. She comes to see you. What happens next?
Well, first thing is there's a lot of anxiety, right? The cancer, the lot of bad thoughts in their head, death, you know, they're thinking about death. A lot of these women are young women, you know, they're working, they've got, young children, very active.
What's the youngest case you've seen?
Youngest I've seen is in my 20s, 20s.
Was there a family history?
Yes, there was a family history. There was a very strong family history. So, there are a lot of fears in their head, and, there's a lot of fear about chemotherapy, what will happen, uncertainty, they don't know what's going to happen to them now, how their life will change, what are the financial implications, So there are a lot of pressures when it's a very, very, what I feel is the first meeting with a breast cancer patient, especially if they're young, it's very charged, their spouse is there, they're crying.
Is there a lot of anger?
Sometimes there is, right? Sometimes there is. Why this happened to me, why not others? So, it can be a very charged specialty, there's a lot of stresses out there, and a lot of these women, they bring their kids also, because there's nobody to take care of these kids. So they're just running around in the clinic sometimes. So once they come to me, we try to educate them. Their concern is whether I will live or die, what will happen to me. So a lot of encouraging statistics. What is the cure rate of this disease? This disease is highly curable if picked up earlier. I tell them a number that it's more than 90% curable in general, if picked up earlier, if it has not spread. So a lot of encouragement needs to be, given to them that, they can go through this. We have done it all the time. There are a lot of young women who worked full time and they went through chemotherapy and they went through whatever is needed. what we try to do is once these patients show up in our clinic, we try to discuss these patients in a multidisciplinary fashion. That is, we have a meeting every week in our hospital where we have medical oncology, radiation oncology, general surgeons are over there, or breast surgeons are there, pathology, radiology. So like 4 or 5 specialties sitting in one room, and we discuss our cases with the whole team, so that we get a consensus that what needs to be done, because there's a lot of modalities in treatment. What comes first? Surgery comes first, chemotherapy comes first, does radiation needs to be involved? There can be a lot of questions about pathology also. At the time of diagnosis, there are a lot of queries we can have, and the clinically disease might look different, but the report they have, it may look very different.
So every different patient will have a different approach.
Yes.
That's the
one
main
size fits all doesn't work here.
Which is quite a misconception.
Right.
Dr. Farooq, I wanted to ask you, radiation oncologist, what is your job and how do you treat the patients?
Radiation is an integral part of treating breast cancer patients. Any patient can be subjected to radiation. And for our audience in general, they must remember it's counterpart of surgery. Sometimes we limit the surgery, we just do lumpectomy and we radiate the breast. So it's not always necessary to remove the entire breast.
Right.
So the concept of breast sparing surgery is well known amongst our community, and most of our patients are well aware of that.
Is that practiced all around the world?
It's practiced, it's a standard of care that now we do not go towards breast mastectomy. You don't need to remove the whole breast, we only remove part of it, which has the disease, and we only treat the cavity as well as the entire breast. So you preserve your breast, your cosmesis, and probably your psyche.
How important is that?
That's very important for the psychological well-being of the patient. When you say somebody is healthy, psyche is an integral part. So imagine a young woman in 30s or 40s getting rid of one breast. That's a lot of psychological trauma for that.
Exactly.
So basically, sometimes we do radiate despite chopping up of the breast, because the chance of disease coming back on the chest as well as the axilla or the lower neck is quite high. So we consolidate it by giving radiation therapy, and there are specific indications when we do it. So not all patients qualify for radiation therapy, but the idea what Kamran was saying, that we look in these individual patients' data set, their case scenarios as a group, and make sure that none of these integral portions of treatment are missed. And that's why we called each cancer patient is treated in an individualized, customized way. So your cancer, your genes, your treatment. So you cannot universalize the treatment that one size fits everybody. That concept is gone now.
Of course.
One thing I would like to add also, that this removing the whole breast, it's a very, very disfiguring surgery. It's a big surgery. It has a lot of long-term sequelae also. So as Farooq said very rightly, that in the West, a lot of people are moving towards breast conserving surgery, and it's being done more and more. Like if you look at the numbers, like 80-90% of the surgeries in the West are all breast conserving now. So they really moved away from this mutilating whole breast removal versus just removing the part. Obviously, there will be certain patients who will not qualify for it. So that's why we need this multidisciplinary approaches where surgeons are there. I may have some preconception that I want to save this woman's breast, but that's a surgeon will have to decide. And sometimes you work together. Sometimes the size is so big that surgeons say that we have to remove the whole breast. So I tell them, no, I can give this lady chemotherapy. I can downsize that lesion, and then we can try, or we can save surgery for later on if it shrinks very well. See, modern chemotherapy is very, very effective. It sometimes shrinks the lesions away completely.
Does that depend on the stage that the patient
Not the stage, the
in?
type of breast cancer. See, the biology. Right now, the current mantra in medical oncology and oncology in general is biology drives the tumor. It's not the size, It's the biology of the
every
disease.
different person
Yes,
and how the
everybody
body
has
is
different
reacting
biology, and
to
there are
it.
certain markers which are being done throughout the world. We do it in our hospital also, which give us a clue about the biology of the disease, that how aggressive this disease is, or how indolent this disease is, whether this patient will benefit from chemotherapy or not. There are certain markers which can help us.
Okay.
Besides, Shabnam, like when we have these patients in our multidisciplinary tumor boards, we not only look into the clinical features, whether the patient is above 50 years, less than 50 years when the disease is supposed to be more aggressive, into their histological features, whether they had lymph nodes or not, or their different things which we look at the pathology, the grade of the tumor, the margin status, and so on and so forth. But we also do a breast profile where we
Okay.
do an ER, estrogen receptors, PR, progesterone receptors, the proliferative index, how quickly the tumor is progressing
Okay.
in the cycle, as well as a specific test called HER2. So based on this, we categorize them into 4 different genetic types. So
Okay.
one of them is like very indolent, it's slow growing. Normally they are dealt with hormonal therapy. They're the
Okay.
type of patient who may not benefit from chemotherapy. Their disease may run for years and relapse at very late stages.
Right.
But then we have got very aggressive tumors which have a very low survival, they come very quickly, and based on these genetic features combined with clinical and pathological features, as a group, we all decide what kind of chemotherapy we need to give. Is it going to be 4 cycles? It's going to
Okay.
be 6 cycles? It's going to be 8 cycles? Usually radiation follows surgery, or if you are doing a breast conservation, a lumpectomy, the radiation comes later. So
Okay.
more or less, every woman should know that once the cancer comes in the biopsy,
Yeah.
their consulting physician is no more a surgeon, pathologist, radiologist, it's an oncologist.
An
So
oncologist.
oncologist is like a pilot who makes your journey through this, I would say, a tedious and cumbersome treatment which lasts from 6 to 9 months. The job of oncologist is to hold your hand and make this journey as convenient as possible. So
Right.
let him be your judge. Have confidence in your oncologist. He will tell you when to go, where to go, and get what.
I think that's a major point that you've raised here, is to have the confidence in the oncologist. I mean, it must be really, really emotionally draining as well, to especially come across patients where you see somebody very young who's coming over, got an aggressive cancer, and you're trying to treat them at the same time you're trying to deal with their emotional upheaval as well, because for them it's a huge shock too.
Absolutely.
So do you involve psychological counselling and psychiatrists as well in your network?
Ideally, I believe they should be involved. There are certain cases in which we feel women are very distressed to a point that may interfere with their treatment.
Okay.
They may not show up at their appointments, or see, the more distressed you are, I believe the side effects of chemotherapy and other treatment modalities, they go up. So it's
Right.
very, very important for the patient to think very positively. I tell my
Okay.
patients again and again that, thinking negatively will never help. Thinking negatively, it will not cure your disease. There are studies which have shown that, if patient thinks positively, the outcomes are very good.
Right.
The side effect profile of drugs, of chemotherapy, of radiation, all these things, they go, the scale goes down.
Okay.
So to answer you, a patient I feel who's very distressed, who's crying all the time, who has, can't sleep, can't do this, gives us a sense that, something is not right, psychologically.
And
So
they
we involve
need
a
extra help.
exactly. So we
They need
involve a
extra help.
psychologist, we involve but in most of the patients, we try to give them this emotional, psychological support. And if we feel that if they need real professional help or some medication, we try to
help them out.
Yeah, right.
Is the word cancer, it's sort of, it just hits a person and then they sort of, they're sidetracked from exactly where they are, fact-wise, and it just seems like a death sentence. Is that true?
Absolutely. Anybody who's performing his daily activities, happy, enjoying life, all of a sudden a lump brings a bump in her life, she's told that you have got a cancer. And then you have those stages from stage 1 to 4, early, confined to the breast, a little late going into your armpit or gone into your mainstream through blood vessels. That would be stage 4.
Right.
But first thing what I would suggest is when we are looking at these patients, we try to be their psychiatrist as well. We are their
Right.
dietitian as well.
Okay.
So we take care of them as a whole. So first thing what we do is we reassure them repeatedly that this is not a disease which is going to be rampant. Science has advanced much, even in stage 4. Gone are the days when your days were numbered. There's modern chemotherapy, more and more science is progressing. Newer drugs are coming. Now, when I started my career way back 25 years ago, if a metastatic stage 4 breast cancer would die in a year and a half, now they can actually, you can see these very commonly patients living 7 years and 10 years
Right.
because of the advent of newer and newer medications, and they're more effective. So you are treated more like diabetes, if
Okay.
not true diabetes, like a chronic disease.
Right.
So we need to reassure them
Yeah.
that we are there to help you. And most of the times in my clinic, I think very rarely I would send somebody, because this reassurance from your first-hand doctor,
Absolutely.
who's your captain,
That's
who's going to
true.
drive through you
Yeah,
the entire
that's absolutely
treatment, that actually gives a good impact in at least
Of
our
course.
society.
Because a confident, when you're seeing
Absolutely.
confident specialists, then of
Yeah.
course you're able to place that confidence inside yourself as
Absolutely.
well, and then it's so much of a boost, that willpower that you need. Dr. Garman, tell us, new drugs on the market. Chemotherapy is often, people associate a lot of unpleasant side effects. What sort of research is going into better drugs? And
I believe
less
there is a exponential growth in new drug development. I was just seeing just reading one article, and they said that within 1 year in US, FDA, the authority which approves these drugs, just for cancer, they've approved like 10, 15 drugs in 1 year. And these are all targeted drugs. So this is an era where newer drugs are being made. And what's happening is now, because of the better understanding of the cancer cells, how they grow, how they develop resistance, there are a lot of pathways which people have come up with. And then to block those pathways, newer drug companies are making newer drugs. And these drugs are very, very effective. There is a target which they hit. And see what happening in chemotherapy was and is that there are targets, but those targets are very crude, and there's a lot of collateral damage like hair loss, nausea, vomiting, and dropping your counts, blood counts. These targeted therapies, they have precise targets, and they're very, very effective in blocking those targets or killing those targets, and they don't have the collateral damage.
Oh, okay.
So what happens is, even today, we have a chemotherapy backbone, but
Okay.
on top of that, we add these newer drugs. Like, for example, he talked about a breast cancer subtype known as HER2 positive. It's a protein expressed on the breast cancer cells, and there's a targeted drug known as Herceptin or trastuzumab that selectively attacks those cells which are overexpressing this protein. So normal cells, they do express this protein, but at a very lower concentration, whereas cancer cells expresses this protein, the certain subtype, at a very high number. So this drug will selectively attack your cancer cells and will
Right.
spare your normal cells. And this
Okay.
is the concept of these targeted therapies, that they will attack the diseased cells, not the healthy cells. In chemotherapy, the problem is the healthy cells are also affected for certain time.
Right.
But with the newer supportive care drugs, the side effects of chemotherapy has also gone dramatically low. See,
Really?
20, 30 years ago, the chemotherapy patients used to get admitted because they used to get chemotherapy, and they used to have so much side effects
From that.
from nausea, vomiting.
right.
But now chemotherapy has become an outpatient procedure. They come,
Okay.
they take chemo, and they go back home
So
the
what
same
about the
day.
hair loss and the nausea?
Well, nausea is controlled. There are very effective drugs. There are 4 or 5 newer drugs out there which are very, very effective. I tell my patients that majority of patients will not have a lot of nausea. There will be certain subset of patients who will be very, very nauseous, whatever what do. But in general, majority of patients tolerate chemotherapy extremely well with very
That
little
is
nausea.
very encouraging.
hair loss is a problem, but there are some newer studies coming out. There is some new caps in US which they have introduced that
Okay.
may decrease the incidence of hair loss. But you know what they're saying is in future, we may have will be targeted drugs
Right.
with
Okay.
very little side effects.
that
We have a
is-
target. See, every patient will have a genomic profile. You know,
Of
patient
course.
comes to you, they biopsy the cancer, it goes to a lab, and then they run a battery of tests on this. There's a new machine out there known as next generation sequencing. What they're doing is they take the sample and they run it through that machine. And that machine can give you certain proteins and certain genes in a certain manner, and then it can tell you what drugs to attack those pathways. These genes are missing, these drugs can be used. So there's a lot of work going on. You know, we used to look at the size of the tumor, the lymph node, but now they're looking at those genes, at those proteins, and offering
Right.
them drugs, making a plan for these
It's sort of
patients
like
based on customized plan. That's actually that's
customized
where we are
treatment.
heading towards in the future. You know.
So that's very, very positive. In fact, if you think of that for people who are going to receive chemotherapy, Dr. Kamran is saying that there are drugs now available on the market that will make the side effects more tolerable. So right now we're going for a break. We'll be back. Don't change the channel. Welcome back to the show. Dr. Farooq, now I'm going to ask you, what exactly is radiation therapy? When is it needed? What are the side effects and the sort of the facts from the myths? Sort them out, please.
Yeah. Thank you, Shabnam. It's a very important part of management of breast cancer patients. Let me reassure our audience that electromagnetic radiation composes of lots of varieties. One of them is light, which we have here in this room. So like X-rays, you do every now and then for chest or abdomen. We use X-rays through a very specialized machine called linear accelerator. And we direct it exactly where it's destined to. That's your chest wall or the lump cavity. And these are normal part of the treatment of these patients. So I don't think there is any reason when you're getting radiation under specialized care hospitals, you shouldn't be afraid of. The reason why we give radiation is simple. We ensure that the chance of disease coming back, despite limited or extensive surgery, we reduce it to minimum. So if we don't get radiation in selected patients, the chance of disease coming back into the chest wall, despite removal of the breast,
And the
because of those high-risk features and chemotherapy, is around 32% when we talk in general.
Okay.
So if we give that part local treatment using radiation
You're providing
therapy,
an extra cover.
so that's an extra consolidation.
Right.
So we reduce it to 10% or less.
Okay.
So there's a substantial improvement in the local control. Not only this, we have lots of trials, evidence that when radiation reduces your risk of recurrence over a decade or more, it actually translates into a survival advantage. And mind you, the audience should know that chemotherapy not only downsizes the tumor, it improves your survival.
Right.
So a long-term effect of radiation comes in transformation into improvement in survival as well. So that's basically why radiation is given.
Right.
So we've got these select indication if the tumor size is above 5 centimeter in the breast, or if you have presence of axillary lymph nodes in the armpit, they qualify for radiation. Then we look at these teeny
So
tiny
not
things.
every patient is
Not
going
every
to get
patient.
radiation.
Plus, patients who want to preserve their breast, where only lumpectomy is done, we would always radiate it to make sure if there are small microscopic deposit left over, they can be taken care of with radiation therapy.
Okay.
Now, having said that, my patients always ask and they seek knowledge about what radiation is going to do. So it's simple. It's not chemotherapy. So it's not going to go into the blood and circulate throughout your body. It's only given to a specific area. So we anticipate local side effects. Most of them come towards the end of radiation in the form of skin reaction, like your child going out in the sun and getting darkened. So sometimes you get redness. When electromagnetic radiation, which is part of the light and X-rays and microwaves and gamma rays, when it strikes the skin, there's hyperpigmentation or tanning, you call.
Is that locally for that place?
That's only for a local area.
All right.
In the chest, sometimes in the lower part of the neck and axially.
Right.
The only thing that happens is sweat glands are knocked down. So you don't have sweat, so it becomes a little dry, so you feel itchy. So you don't need to scratch it because you're going to peel it off. The skin become very dry, can easily be peeled off. Second thing is,
so what's the care for that?
just keep it dry and
Any
aerated.
lotion,
So we don't ask patients to wear anything other than cotton, because cotton is aerated compared to anything else like silk, and polyester, which is going to cause damage to your skin. We don't allow them to have any sort of undergarments. And armpit is quite wet. So in select patients where axilla is being irradiated, that sweat is picked up by the dry skin very quickly, and then it peels off. Then we call it a radiation burn. So that's sometimes very painful, but this occurs in very, very few patients. I would say 4 out of 100, 5 out of 100. Good radiation technique, weekly checkups, and application of some gels on the area during and immediately after completing radiation actually can prevent it. So these are type of local things that can happen. We always take care through a specific technique we call 3-dimensional conformal radiotherapy, where these patients who have breast cancer on the left side, we try to save the heart, which has been exposed to adriamycin or chemotherapy. So it becomes a little sensitive, and portion of lung that comes in the radiation field. So we minimize it by this technique, and we have these linear accelerators and softwares, which are, they act like drones. They target the area where radiation needs to go, and they save the collateral damage by preventing radiation going into. And this can actually be seen on a monitor where we actually plan it. And then with these limitation or constraints, we call them, that heart should not exceed this kind of radiation, portion of lung should not get beyond a particular dose of radiation. So when all these criteria are met, we verify a plan. So it's perfectly safe. Not only it's safe on the computer, this execution is also safe.
Also very safe as well. Okay. Dr. Kamran, I'd like to ask you, this question. We were talking about, breast cancer in particular today, but then cancer in general. What lifestyle changes need to be made to make a person, less at risk?
That's a very good, very important question. A lot of my patients, they're very concerned, especially the families next to the patient, they're all scared. So they always ask me, and I also tell my patients, we have done the treatment, and they always ask me, what can I do, to fight this disease?
A genuine question, because they're...
So once I finish the treatment, I tell them, now it's your time to do something. And I tell them that there are 3-4 things which they need to be very, very vigilant about. One is daily exercise. There's a lot of studies, a lot of data coming out that working out daily, any aerobic, anaerobic activity, isotonic, isometric exercise has shown to decrease the prevalence of heart disease as well as the cancer. There are certain studies in which colon cancer survivors, it's a study done by Dana-Farber people, Mass General Hospital, and what they showed was that people who were the most active, there were like 3 levels of activity in the study, and the people who were the most active in the study had the lowest risk of recurrence of colon cancer. So there's a lot of data coming out. People in the West are very, very active, survivors are very active physically, So that's one thing they need to know about. Second is your diet. So
these are survivors. What about people
who don't have it? Even for them also, there are studies coming out, epidemiological studies, that people who are physically active, like they walk, they swim, they jog, they work out in the gym, they have a lower incidence of cancers down the road.
What about stress?
stress is another factor which I tell my patients that they need to try to, they need to control the stress factor, stress leads to certain release of chemicals in your body, and some of these chemicals can promote growth of cancerous cells.
Okay.
So controlling, stress, leading a stress-free lifestyle, if, in their constraints, whatever they can do, that's very, very important. And also diet, you are what you eat. That's what I used to hear when I was a kid, and that holds in my specialty. 100% true.
What
So
should we not
eating,
be eating?
healthy food like salads, fruits, vegetables, staying away from sugars, processed food, meat products. You can eat, junk food, burgers, pizzas. You can eat it once a week or once a month with your family. That's fine. That's
What about once a week? Because
Now,
you
once
see
a-
children
Yeah.
indulging a lot in this. So what would you say would be a
once a
safe-
week should be fine. Once a
Okay.
week should be fine. But doing it every day, processed sugars, processed meat, and sugary food. Try to replace it with healthy alternative. See, when we were in training, we used to hear about that all these things lead to higher incidence of heart disease. But now the newer data which is coming out is saying that higher incidence of cancers also. All these cancers are tied down to this unhealthy lifestyle.
Right.
There are 13 cancers which are associated with obesity. If you are obese, if you're overweight, there are 13 cancers which are associated with it. So it's I believe it's a lifestyle change. It's a lifestyle modification, and I believe it has to be taken very, very seriously.
Very, very seriously. Dr. Farooq, I'm going to ask you, we haven't talked about this in the program, male breast cancer. How common is that, and what are the symptoms?
Every now and then, it's rare, but every now and then we do see a male cancer patient who has a lump in the breast, and we find that it turns out to be cancer through mammography or ultrasound and doing a needle aspiration or biopsy. So it's extremely rare.
Extremely
If
rare.
you have got breast cancer patients, 1 out of 1,000 would be a male.
I see.
Obviously, if you've got a male cancer, they're probably treated in the same lines as a female does,
Right.
but a male cancer should prompt that there may be a mutation in the family. Like a female, they run vertically in your nani or your great-grandmother or father, and then coming down, or laterally, horizontal, your first cousin, second cousins, your sister. So
Okay.
similarly, having a male cancer in the family
Right.
should prompt you that maybe it's a genetic disease.
Okay.
Usually occurs in elderly, but a BRCA positive male breast cancer would come in an earlier stage rather than an older stage. Similar risk factors are involved. We must remember in females, it's an estrogen-driven cancer. So
Okay.
estrogen
Which means
cholesterol. So cholesterol is the precursor of estrogen. So females who have early menarche, late menopause, who do not marry till 30 years, who do not breastfeed, because all these are diversions to cholesterol, to the estrogen. So they start looking at the milk, so they don't expose the breast to excess amount of estrogen. Similarly, diet rich in cholesterol is going to do the same. What your endogenous cholesterol is doing. So these are the kind of things our audience should remember. A daily activity, as Dr. Kamran said, is integral. WHO recommends half an hour walk,
Half
at
an hour
least
walk.
every day, 5 days a week.
5 days a week. Okay.
So you're allowed to eat.
And that means a walk where you can feel that,
Right.
your heart is pumping,
Right.
not just a
Absolutely.
calm sort of stroll
Absolutely.
outside.
So these are the kind of things. Cigarette smoking.
Yes.
People women who feed their child for a year and above, they have a reduced chance of having cancer.
Again, the importance of breastfeeding.
Yeah.
That is just so important, because you see so many young mothers who will try, and then because they come across a few problems, they'll think, it's easier to give a baby, but then it's detrimental in both ways, because it's not good for the baby, and it's, as you said, it's not good for the mother as well. It's better if she does breastfeed.
And Shabnam, like estrogen pills for birth control.
Oral contraceptive.
You should be very careful because there are studies taking them beyond 2 to 3 years can actually substantially increase your risk.
Right.
So you should rather, consult your gynecologist.
And have some
and,
other
and
method
you may
of
have
birth control.
another method to do
Okay,
it.
that's right.
Especially if you have a family history, then you are even at higher risk. So
Okay.
you need to tell your gynecologist that I have family history and they need to know this. And one thing about these lifestyle changes, it has to be done very slowly.
Of course.
Slowly, gradually.
not
See, a
overwhelmed.
woman who's taken chemotherapy for 6 months, surgery, radiation, these women are very run down. So if you tell them you start walking half an hour, it'll be very difficult for them. So you just tell them whatever you can do, but try to reach this level in the next 3, 4, 5 months. Set a goal,
Baby
and then
steps.
just persist with that lifestyle.
Okay,
And
that's
one
right.
thing happens is after the stress, the women are very into it that they're going to change everything. But
Of
as
course.
they move
They have
away
to
from this
realistic
stressor,
goals.
they just start going back to
that's
their
true.
previous lifestyle.
One thing I wanted to talk about as well, because we're part of this Pink Ribbon campaign, and it's really, really important, you've taken out time from your busy schedules as well. We're talking to our audience, this is in a series of programs. We're talking about breast cancer awareness, and what we want to do is also tell our viewers that this is something that you shouldn't be shy about. You mustn't be shy about, in fact. How do you counsel patients as well who you've seen come to you at later stages only because they were embarrassed to talk about this?
This is a common problem. Despite being in 2017, I think 2/3 of our patients come in very advanced stages.
Just because of this reason?
Oh, yeah, and quite often we see these cauliflower-like ugly masses coming out of the breast. So when we ask them, we say, our husband didn't allow, or they were shy, probably in denial,
Right.
that if it turns out to be a cancer, they're going to be subjected to extreme treatment, including chemotherapy.
Of course.
So these are their social taboos, their economic pressures as well coming on to
So
them.
how can we help to, break those taboos? And
To be honest, in my personal experience, once the patient develops cancer and she has this confidence in the team that this has been taken care of, and it's quite reassuring for them, they become our ambassadors in a way.
That's
They go
true.
back and tell their colleagues, their family, that this is something which is treatable.
and you have to talk about it.
And you need to talk about them.
Yeah.
And programs like these, which we are just conducting, we use media, we do these walks and campaigns.
Right.
These are actually making it more and more aware. And I think it's important to integrate girls from younger age,
Right.
going to their schools, organizing them, making them part of this campaign. So if you're doing a walk,
True.
ensure that girls from these schools and colleges, they're part of the walk.
And not just the girls, the men as well,
The men as well,
boys
of
as well,
course,
so that
yeah.
then again, because they're the ones who are going to bring them forward.
Right,
Absolutely.
right.
To educate them as well is very
Right.
important.
And the audience should remember, when you develop cancer, breast cancer or any cancer, it's going to have a great social impact. Not only traumatizing you physically, draining you mentally, but also draining you financially. So the more advanced you come, the more chances you'll get all surgery, radiation, chemotherapy, targeted therapy. So the treatment is going to be longer, the cost
Outcomes.
is going to be longer. So the misery is going to be longer. So you pick it early. It's a disease which is screenable. It's a disease which is preventable through lifestyle changes we discussed.
Yeah.
So try prevent it. If you don't, you are at high risk. You have a family history coming from your grandparents or going sideways towards your sister and first and second degree relatives. They need to screen them early.
Okay.
The WHO recommends 40 years and above as a screenable limit for a normal individual, but we sometimes do it early if it runs in the families.
Okay.
Yeah.
Yes.
One thing that has to be drilled in the minds of the masses is that cancer is a race against time. Every minute, every day counts. If you ignore this disease will spread. So the earlier it's picked up, earlier treatment, higher the cure rate. See, the numbers for breast cancer, if picked up earlier on, it's like it's at more than 90% chances of cure. It's very high,
Very
high. But the
encouraging.
thing is that the longer it takes, the more difficult, the more money spent, the misery is higher, and the outcomes are not very good. So
And again, this is all leading back to our programs when we said to our viewers that, the self-breast exams, being vigilant yourselves, speaking, the network within the family as well, you know, the aunts, the sisters, the cousins, the mother, that should also be very, you know, strengthened, where they should be able to discuss these things as well.
Right.
Absolutely.
Yeah, right. Okay, what about cancer in pregnancy? We're running out of time a bit, so we're just briefly, cancer in pregnancy, breast cancer, how is that treated?
It's very uncommon, but we see it, you know, in a bigger hospital, we see that. The problem is you have a developing baby inside the mother. In the first trimester, if it's picked up, it's very problematic to treat it because you cannot give chemotherapy. These chemotherapy agents can damage the fetus. So usually in the first trimester, we offer a woman abortion to get themselves aborted, and the treatment, you know, then we start the treatment. In second trimester and third trimester, treatment can be done safely. There are many studies which have shown that these women were given chemotherapy and the outcome of the babies were very healthy, very normal babies. And what we have seen is during pregnancy, breast cancer is very, very explosive. It's a very aggressive cancer. So it has to be treated very, very
because of
aggressively.
the hormones?
Hormonal changes, the body is growing, everything is growing. Ages are very young, you know. Young age cancers are very aggressive cancers.
Okay.
And especially if it comes in the pregnancy, you know, it's and sometimes it's very difficult for the women to pick up because the breast gets engorged, it's they're lumpy, bumpy, and feeling a lump inside the breast can, you know, become very, very difficult for these women. But if it's picked up, it has to be treated ASAP. There's a lot of dilemmas that babies inside, you know, what will happen. If it's first trimester, we have to talk to them about abortion, and the decisions have to be made very, very quickly, and we have to move on very quickly because if it's delayed, if we cannot wait for the fetus to deliver and then we start treatment.
Okay,
You know?
as you said, it's
Yeah.
a race
And
against
you know,
time.
when the audience should also know, first trimester is the first 3 months
Right.
when they've been diagnosed. So we are not in a hurry as well. But what Kamran means is, like, if you've got 2 months, there's always a chance you can give them a month. Because this is the time when the organogenesis, the organs are being formed.
Right.
So if you subject them to these chemicals, there's a chance these organs will not be formed properly,
Right.
so there may be defects.
Might
So
be
once the
harmful.
3 months passes, it's
when
absolutely
you're
safe. So you
that's
have incidentally chemotherapy and surgery, which can safely be done. We usually avoid radiation in pregnancy.
Okay,
Yeah,
right.
but there are instances where we can give them. Yeah.
Dr. Kamran, Dr. Farooq, thank you so much for being with us here today to be part of such an important series of programs and part of this Pink Ribbon campaign as well. Thank you very
You're
much.
welcome.
Thank you very
Thank
much,
you.
Shabnam.
Okay, and with that we come to the end of today's program. We really hope that you have picked up so much extra knowledge here with our experts who have been with us in the studio. This is something that, you know, it can affect anybody. So be vigilant and learn from all those things, all those gems of wisdom that we've been able to share. So until next week, stay happy, stay healthy. Bye-bye.